Welcome, everyone. My name is Julia Wall. I'm the Director of Education at the Michigan Parkinson Foundation. This is our virtual education program that takes place monthly. And tonight we are very excited to learn more about a very popular therapy that has been emerging in the news, and that is called focused ultrasound. Tonight's presentation is going to be with Dr. Li from Corewell Health in Grand Rapids. Dr. Li is a board eligible physician specializing in functional neurosurgery. My screen just went blank, sorry. He completed his medical school at Medical College of Wisconsin and residency at the University of Iowa Hospitals, and his fellowship program at Oregon Health and Science University School of Medicine. We're going to get started here shortly. I just wanted to remind people that next month we will not be having our virtual education program just because our leadership summit meeting will be taking place in Port Huron. So the next virtual education program is scheduled for August 20th when Dr. Erin Ellenbogen will be presenting. This program will be sponsored by Amneal Pharmaceuticals. And typically when it's sponsored by a pharmaceutical company, we cannot record the presentation. So when we have all the information, you'll get an email, and of course, we'll post it on our social media. So Dr. Li, are you all set? You might have to unmute yourself because I might have.
Yes.
Oh,
Can you hear me?
yes. Yes. So with that being said, I would like to introduce Dr. Li to you and take it away.
Okay. Hello, everyone. Thank you for everyone's time tonight. My name is Luyuan Li. I'm one of the functional neurosurgeon in Grand Rapids. Like Julia said, I did my residency training at Iowa, and then I finished my functional neurosurgery fellowship last year on the West Coast in Portland, Oregon. And that's kind of where I learn about doing deep brain stimulation with patient asleep, and I learn about focused ultrasound. As a functional neurosurgeon, I feel I seen firsthand for many years how Parkinson's disease, essential tremor, how they can strip away patients like independence. Turning simple things like drink a glass of water with one hand, writing your name on a check into a daily struggle. And it's also not just a disease for the patients, it's also for their family members. It's sometimes as the disease progresses, you require more and more care by the family members. So my goal has always been to bring kind of the most cutting edge and the least invasive therapy for the patient. And I learned about the focused ultrasound procedure during my fellowship. I was really impressed by the outcome. That's why I've been working with the health system here to try to bring the technology here. And we're lucky like to be able to start a program here and start our first treatment last month. So I don't have any conflict of interest with anything discussed today. And in terms of overview, I'll just first talk about deep brain stimulation for Parkinson's disease briefly. Because as a functional surgeon, I do both procedures. I don't have any bias. I think in the end, I think it's about the right procedure for the right patient, and is there a different indication for both? And in the end, I think we make a decision together to decide which procedure is right for you. Okay, and then I'll talk about the focused ultrasound for tremor-dominant Parkinson's disease. I'll talk about the outcome, what's it like for the patient, and we'll save some time for questions at the end. So as we know, Parkinson's disease, there are many ways to treat this. Usually you always start with medication, like Sinemet. And at the same time, usually most patients with Parkinson's disease will benefit from aerobic exercise. There was some big study done during my training in Iowa that, we proved that aerobic exercise really can slow down sometimes the progression of Parkinson's disease and improve patients' quality of life. But as we know, with movement disorder, as we age, the symptom usually gets worse. The dopamine levels in our body continue to decline. I think when your symptoms can no longer be well controlled with medication, when your quality of life are still significantly affected despite your own medication, that is when we think about procedural treatment for the right patient. So what are the procedures available for the patient? Right now, there are four procedures we can do. Number one, which was the most popular treatment for patients with Parkinson's disease, is deep brain stimulation. The second is focused ultrasound. Then some people also heard about radio frequency ablation. That was an older procedure before the kind of the development of DBS in the early 90s. In some patients, they may try gamma knife, which is a radiation therapy. So, the surgery for Parkinson's disease actually has a very long history. Initially through serendipitously, in a patient with PD after stroke, we realized, patient's tremor got better. That is when the neurosurgeon, I think at that time mostly in Europe, to really learn about the basal ganglia, the deep part of the brain, and how the different circuits in the brain are involved in Parkinson's disease. That's also how to develop treatment, different targets for Parkinson's disease. So, so out of all the four treatment I talk about, basically there can be two types. One is DBS, deep brain stimulation, which is using electricity to modulate the brain. These are types called a lesional therapy, which is make a lesion in the brain. So either through a focused ultrasound, through a radio frequency ablation, or through the radiation therapy. So what is deep brain stimulation? So when the dopamine levels in the brain gets decreased, the different circuits in the brain, some gets activated, some gets inactivated. Deep brain stimulation, just like pacemaker, we use a wire placed in the brain and using electricity to restore the normal circuitry in the brain, so that kind of patient's movement symptoms like the rigidity, the tightness of muscle, the slowness of movements, and your tremor will get better after we turn on the stimulation and restore the circuitry in the brain. And why do we want to do deep brain stimulation? Because in the end, it's about your quality of life. We know from many studies that deep brain stimulation improves your motor function, can reduce your dyskinesia, and sometimes can reduce the medication dose, increase on time. On this graph here, this line means time of the day. This line means the dose of the levodopa. And the turquoise color here is a sweet spot of your medication when your medication is working well. As the Parkinson's disease progress, patient develop more and more time in the off time. What does that mean? That just means that in a lot of times during your day, after you take a dose of medication, the medication dose is either too low to control your symptoms, or medication dose is too high for you that you have all these unwanted movements. After DBS, the goal is that to increase your time in this turquoise color, increase the time when medication is controlling your symptoms for the majority part of the day. And as a result, we can improve your quality of life. So how is the DBS done? Usually in most places, it was usually done in two stages. With first stage, usually the patient can be either asleep or awake, or putting electrodes in both sides of the brain, and usually stay in the hospital overnight. And then the focus for the second stage procedure, usually a few days or 1 week later, we'll put the kind of extension wire and the generator, like pacemaker, in your chest, and usually done asleep. So personally, I did a deep brain stimulation surgery while with patient awake for 7 years. Then when I did my fellowship, I went to Poland to learn about sleep DBS, because in my experience of doing DBS awake for 7 years, I do feel like some patients really did not tolerate the procedure super well with being awake and with being off medication for hours, sometimes 8 hours, 9 hours. And it's not a great experience for the patient. And my mentor, Dr. Birchall there, he was the first person who did DBS in the United States in the early 90s. And he popularized the way to do DBS asleep. That's why I went there and learned about the procedures. So how I do them is actually I use a robot and you'll be asleep. Like you won't like you just go to OR, they'll intubate you, you'll be asleep, and I connect you to a robot. We use robots to guide me to the right place in the brain based on advanced imaging, based on the MRI. And then after electrodes are in place, I get a CT scan while you sleep in the operating room, make sure electrodes are in the right place. Then I just put everything together, close you up, and you wake up, and that's it. Well, for the second part, usually you'll be asleep for that as well. Usually takes about 1 hour. We place the extension wire and battery in your chest. Then you just go home the same day. So I won't for me personally, I my preference to do the DBS asleep, and I also published paper on this because we know we show that it is very safe and effective for the patient. It's much better comfort for the patients because you don't have to stop your medication. You don't have to do the intraop testing. You don't have to be awake when we are kind of like when you're like opening you making incision on your head, and it's also faster. You can go home earlier, and as a result, patient has better comfort. And all the results show that there's really no difference between doing DBS surgery awake and asleep. So this is DBS. So during my fellowship, I also trained with Dr. Rassen, and he did focused ultrasound. And so we know 75% patients with Parkinson's disease can developing a rest tremors. You know, the tremor you have when you're resting, but something goes away when you're moving using your hand, using your arms. This tremors mostly affects the hands, but the disease progress can also affect the legs, the lips, the chin, the jaw, and the tremor usually gets worse, you know, when you are distracted or when you feel very stressed. And in some patients, even though the other parts of Parkinson's symptoms can be controlled with medication, but for reasons we still don't know, this tremor can be very resistant to medical therapy. So the actual basis, the science behind focused ultrasound is very similar to the deep brain stimulation, to the radio frequency ablation, to the gamma knife. With focused ultrasound, we are actually targeting the same spot in the brain called thalamus, ventral intermediate nucleus of thalamus. So why do we target there? Because right now, the theory is that the reason why people have tremor is because there's abnormal signal going on in the brain. And one of the signal relays through this relay center in the brain called thalamus. We realize if we can make a lesion there, either through focused ultrasound, sound wave, or through deep brain stimulation through electricity, we can disrupt this abnormal signal, patient tremor will just go away at the same time. So as the actual target in the brain is the same. It's just how do we get there? Use different technology. So why is called MRI guided focused ultrasound? It's MRI guided because the whole procedure actually is only done in the MRI scanner. And it's almost like you go to get an MRI of your brain. You know, you come to getting on the MRI table, we'll get a scan of your brain. Based on scan, we'll plan a target in your brain. And during the whole procedure, we will constantly monitoring the procedure using the MRI. That's why it's called MRI guided. And what do we mean by focused ultrasound? So we all know about ultrasound of the heart, you know, to make sure your heart's doing okay. The prenatal ultrasound to look at the baby. It's the same ultrasound wave, okay? The difference is that instead of one ultrasound generator, like for the prenatal ultrasound, we actually have 1,000 ultrasound generator, and they focus all the sound wave into one spot in the brain to heat it up to a certain temperature so that we can make a lesion in the brain to stop the tremor. That's called focused ultrasound. And during the procedure, you know, we don't make any incisions, so you actually be awake the whole time. And the actual time with your head in the MRI coil is actually maybe only 20 minutes. but the procedure itself probably may take about 1 hour on the MRI table. And during the whole time, I'll be in and out of MRI with you, checking on you. Make sure you're doing okay. Make sure we're on the right target. Make sure your tremor goes away. At the same time, during the treatment, we are constantly monitoring on the MRI the lesion we're making. We'll monitor temperatures. Make sure, number one, we make sure there's no side effects. Number two, we make sure that we can reach high enough temperature so we can make a lesion in your brain so that it will last. The improvement of the tremor will last for you. So what are the benefits of a focused ultrasound? Number one, it's minimally invasive. There's no incision. There's no anesthesia. Because of that, you can go home. That's why you can go home on the same day. It does not require any implants because we are making a lesion. There's no adjustment needed after this because it's permanent. So there's no implants involved. Because there's no implants, there's no anesthesia involved, there's no incision, so that the age and all the other medical problems become a less of a limiting factors compared to candidacy for deep brain stimulation. But focused ultrasound can only treat one side at a time, one hand at a time. With DBS, we do both sides. Focused ultrasound, we can only do one side. But with focused ultrasound, because we're making a lesion, we can you should be able to see the improvement of your tremor on the same day on the MRI table before you go home. So what are indications? So focused ultrasound is for patients either with essential tremor or tremor-dominant Parkinson's disease. You have need to try multiple medication, and you had and also medication has, and we need to show that medication are no longer controlling your symptoms well. Also, you need to be able to get MRI. If you have sharpness in your brain, you cannot get MRI. We cannot do focused ultrasound. And we do have, because the ultrasound wave has to transmit through the scalp and the bone. In order for the accuracy, we have to shape your head so that the ultrasound wave can penetrate your skull accurately. And it is covered by most insurance plans. So is focused ultrasound actually expanded therapy? Actually, it was idea first started in about 20 years ago, and was first approved for essential tremor in 2016 by the FDA. It gained FDA approval for Parkinson's disease in 2018, and has been covered by Medicare since 2018 as well. And about 2 years ago, it was covered for the second setting for patients with essential tremor. So what is actually like for you as a patient to undergo this procedure if we deem you a candidate? Let's say you're the first patient of the day. Usually you'll get to the MRI facility, just in the MRI around 7 o'clock in the morning. We'll change into a gown. We'll shape your head. We'll give you some medication to help with kind of like swelling the brain after the procedure. Give you some medication to help with nausea, vomiting that can happen with the procedure, and some pain medication. And then, just like a dental office, we'll actually give you some local anesthetics in the front and back part of the head. And we do have to put your head in a frame. The reason why I have to put your head in a frame is that the procedure is very precise. The lesion we made in making the brain is only a size of a small pea. So we have to make sure your head does not move during the procedure. That's why we have to put your head in a frame and secure that frame to the MRI table. So during the 1 hour procedure, you cannot move your head. You will still be able to move your arms, your legs, just not your head. And also do a spiral test to look at tremors. The beauty of focused ultrasound is that we can test the progress, improvement of tremor while you are in the MRI. And if the target is not right, we can just easily move the target on the computer without putting like another lead in the brain. And because of that, we need your feedback. That's why you have to be awake during the procedure. And next thing is that we'll put it on the MRI scanner. We'll get 8 to 10 minutes high resolution MRI of your brain. And based on that, I'll plan the target. For the right hand, we target the left brain, so vice versa. Then after we find the target, actually we do a couple of doses of low dose testing. Well, what I mean by that is that once you heat up your brain to the target to about 50 degrees Celsius, that temperature will not permanently make a lesion in your brain, but will temporarily stunt your brain, as if we make a lesion there. So that's how I know I'm actually in the right target. Only if I make sure that your tremor is better, I'm on the right target. That's when I move on to the next step of final ablation. This requires it's one-time lesioning. This sometimes takes about 10 seconds to about, I would say 30, 40 seconds in most patients, depending on how thick the skull is. And during that time, you'll probably feel very hot on your scalp. And also some patients told me they'll feel like they're floating in like elevating in the air, or even though they're laying down, or feel like they're falling backwards. I do have to say it's not a very comfortable sensation, but also most patients tolerate it pretty well. And after that, you should see your tremor improved right after the like 10 to 30 seconds ablation. And then we just take you off the MRI scanner, bring you to a room, take the frame off, test your tremor again, make sure you're doing well, give you some snacks, relax. You want to make sure your blood pressure is okay. Then you just go home on the same day. And this is a video provided by the company. I do find it pretty helpful. So I'll just play this.
Down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects.
All right. So I think in the end, this procedure about quality of life. And this patient, one patient of mine doing my fellowship, you can see at 7:30, patients still have the resting tremor on the spiral test, on the line test, and 8:30 on the same day after the MRI, after substructural ablation, you can see the tremor has much improved. And this is a patient, I think, before and after procedure. The patient can actually drink water with one hand again, no longer have difficulty pour a glass of water. So what are the long-term outcome and side effects of focused ultrasound? The latest paper are saying that, most patients still have at least about 50 to 70% tremor relief at 3 and 5 years follow-up. But it is, even though we don't make an incision on the head, we're still making a lesion in the brain. So it does come with side effects. And I do want patient to pay attention to that. From my personal experience, the most common side effects is actually imbalance problem of the procedure. The reason why is that with focused ultrasound, we are heating the target to a certain temperature, like 54 degrees, 55 degrees. But the area surrounding this will still heat up to a temperature about 50 degrees. That will not cause any permanent damage to the brain, but in the immediate short time period, you have some swelling in that area. And that swelling in the brain can affect your sensory centers in the brain. That can cause patients to have some balance. That's why when patients come to see me in clinic, I have all my patients to see the physical therapy on the same day they see me to get a baseline kind of like balance test to see how well your balance is. Because I usually tell my patients, if you don't use anything to walk right now, you probably need a cane for about 2 to 4 weeks. If you already use a cane, you should probably need a walker for a while. If you're already using a walker, maybe we should think about getting a wheelchair. All of these balance problems are temporary. It's from brain swelling. Usually it goes away in about 2 to 4 weeks. But I want to make sure patients are mentally prepared that they are going to have side effects. I also give patients steroid after procedure to reduce the side effects. But I think the key for me is number one, do no harm. Make sure you are safe. Number two is make sure you improve your tremors. There's really no severe long-term adverse events. in some patients, they may still develop some tingling numbness and balance problems, like long term. But I would say with improvement in technology, with the newer generation of machine with more advanced imaging, we can really reduce the side effects more and more from my experience. So with the latest technology, it's called the Prime system. I personally actually use the older generation of focused ultrasound for 6 months, and also use a new one for 6 months during my fellowship. And the difference is tremendous because now we're able to get a more advanced imaging. We can actually see more accurately where I'm making a lesion in the brain and where we are heating up in the brain. And we can monitor heat spread and avoid any heat spread to the structures we don't want in the brain. So comparing focused ultrasound, deep brain stimulation, radio frequency ablation, gamma knives, what are really the differences? I think in terms of outcome, I think focused ultrasound DBS can both achieve excellent outcome for the patient compared to the other two options. Because focused ultrasound is incisionless, so the procedural risk is relatively low. DBS, because in the end it does require implant, it does require incision on your head, it does come with inherent risk of bleeding and infection. Unfortunately, with any open surgery, that just come with surgery itself. In terms of side effects, neither will have any long-term side effects. But DBS, we can do both sides at the same time. With focused ultrasound, we can only do one side at a time. With DBS, you may have to wait 1 month, 2 weeks, 1 month, 2 months after the procedure to get DBS turned on to get the benefits. With a focused ultrasound, you should be able to see immediate relief of your tremor on the day of the procedure before you go home. And so in for conclusion, I think both DBS and focused ultrasound improve quality of life. But DBS will help with the tremor, the shaking, the muscle tightness, and the slowness of movements. Focused ultrasound, because the target, mostly just help with the tremor. In some patients, they say they feel less tight as well, but I will say the focused ultrasound mostly help with the tremor of Parkinson's disease. And I think, in the end, I cannot do this by myself. It takes a team to do all this. I work closely with the nurse navigator, Josie, and Jamie, my neurology colleagues, my neurosurgery colleague, Dr. Boyce. We also work closely with speech pathologists, physical therapists, occupational therapists, and neuropsychologists, because we want to treat as a whole person, not just, I'm not just doing the procedure. We want to make sure in the end, the procedure itself fits your goal and could potentially help you for your quality of life. We want to do the right procedure for the right patient. And if you're interested in focused ultrasound, just email us or call us, leave us a message. We'll contact you. But I think if you are Parkinson's disease and you're interested in any procedure, I will definitely talk to your movement disorder neurologist first before you talk to us. Because, and personally, I've been also talking to different neurologists in the state to actually teach them about focused ultrasound too, because it's relatively new technology. But in the end, I think you, your movement disorder neurologist, and I will come together and decide what is the best treatment options for you. That's it. Thank you, everyone.
Oh, that was wonderful. So interesting, and how innovative the technology has become. It's fascinating. We have a couple of questions in the chat. So let's see. 3 years ago, I had gamma knife radiation for a benign meningioma at Mayo Clinic. The meningioma was not near any vital parts of my brain. It was considered successful. Would I still be eligible for this procedure? It is very similar to gamma knife.
Yes, you are so eligible. It's just gamma knife, use radiation. These days, to be honest, is mostly used for like tumor, like meningioma, like you have. Having gamma knife does not prevent you from getting focused ultrasound itself, because it's also different targets. The reason why focused ultrasound is better than gamma knife is that because in the end, sometimes we cannot see the target in the brain. So during the procedure, we do a low dose testing to actually make sure we find the right target. And so we can get immediate feedback from the patient. With gamma knife, with radiation, it takes much longer time for it to take effect. So we can go get feedback. That's why gamma knife is not a good option for movement disorder anymore compared to the focused ultrasound. But gamma knife for tumor will not prevent you from getting focused ultrasound.
Oh, good. So that kind of goes along with our next comment. Phyllis said she had DBS in 2015.
Mhm.
How long does the procedure help the patient? If it is limited, is it possible to have focused ultrasound?
So do you mean that you still have the DBS implant in the brain? So yes, so if you have a DBS implant in the brain, unfortunately we cannot do focused ultrasound because the DBS leads itself and the implant will affect the ultrasound wave and deflect the wave. That's why if you already have DBS, unfortunately you're not candidate for focused ultrasound unless you remove the DBS implant. But the other, but you know, but we can definitely do DBS after focused ultrasound. I've done that as well. Like if you try the focused ultrasound, you get symptom relief, but over a few years, it's no longer working for you as the disease progress. We can still do DBS.
Okay, great. And then we had another question. What qualifies a patient for these treatments?
I think depends on indication. I think okay, if you have Parkinson's disease, I would say talk to the movement disorder neurologist. Talk to them about your options and if they think you're a candidate, ask them to send me a referral. Just give us a call or send me us an email. We'll contact you. Or ask a neurologist send us a referral. Just talk to me at Corewell Health in Grand Rapids, and I will communicate directly with the neurologist and decide what's the best treatment options for you. But because I think Parkinson's disease, is a very complex disease compared to essential tremor, it requires is much more. It requires a lot of medication involved, and patient has a lot more symptoms in addition to tremors. That's why I think it's important you talk to the movement disorder, your neurologist before talking to me, so that we are all on the same page and makes the best decision for you.
So is earlier in the presentation you mentioned that maybe age may not be a factor like it is with DBS. Is
Mhm.
there a certain age or is it very individualized?
I think it's very individualized. Oldest I
Okay.
treat is over 90 years old, I will say. The
Oh,
patient I treat
wow.
today is 86-year-old.
Oh,
Yeah,
wow.
yeah.
Great.
But I think in some place, I think Florida, they treat over 100 years old.
Wow.
Yeah.
That's
I
amazing.
mean, I'm sure, every patient is different,
Yeah.
I have some patients who are in their 60s, they don't look 60s. Or some patients who are 80s, they really don't look 80s at all. So, I think the individual patient based, also depends on your other medical problems.
Okay. I have a couple questions. If people still want to put questions in their chat box, in the chat, that's fine. We'll get to them. One of the questions I had is, does the lesion change over time? And I know you had referenced 3 to 5 years is what considered probably like the honeymoon phase, I'm thinking of this procedure.
I think, to be honest with you, I think really in the end, needs a focused ultrasound or DBS, we are not really slow down the progression of disease. We are just help with the symptoms.
Right.
With DBS, DBS has been around for about 30 years, so we have more long-term data on its kind of like its effectiveness over 10 to 20 year period.
Hmm.
Focused ultrasound is still relatively new.
Hmm.
That is why we only have data up to 3 to 5 years. How
Okay.
are they going to do in 10 years? I don't think we know yet, I will say. But at 3 to 5 years, I think the majority of patients on average, patients will have 70% tremor improvement at 5 years.
Oh,
Yeah. But what's going to happen in 10 years? I don't think we know yet. I don't think we have enough data to know that yet. Yeah. But for DBS, we know for sure it will work. But
sure.
it's interesting. I can tell you, I can tell one story. I don't know, it's just one patient, so you can take into account. I was doing my fellowship. It's for a patient with essential tremor. Patient has a thalamotomy, just destructive procedure in one side of the brain, and the DBS in the other side of the brain. For reasons I don't understand, the hand treated by the thalamotomy, the lesioning, is actually still well controlled. The hand treated by the DB is actually no longer being well controlled, no matter what DBS setting is. So I don't think we know yet, because to be honest, in the end, we don't really exactly know how any of this really the true scientific mechanism behind this. We know it works, but we know if we do this, it works. But the really underlying mechanism, I think we're still studying this. But in terms of if you ask about the outcome, what I can say is that in 3 to 5 years, majority of patients still have benefits from the procedure.
And I know you said that in 2018, focused ultrasound was first approved and Medicare paid for one side. Is there any talk about it being covered for the second side 9 months later, or is
I
any?
think for essential tremor, it's a lot easier. Yes, they will
Yeah,
be covered. For Parkinson's disease, I would say what needs, I think, needs more time for that to be covered, and also depending on symptoms too. You know, I do think the second side thalamotomy, like second side procedure, does carry even a little bit more side effects than the first side. So it's really a patient-based experience. If you think treating one side will really improve your quality of life, I think focused ultrasound is the right procedure for you. If you feel like, you know what, treating one side will not help me at all, I need to have my both hand treated in order for me to have much better quality of life, then I was think maybe DBS is even better options for you. But in the end, it's really about what you want and what the patient, what matters for you, because in
right.
the end, I see patients with movement disorder every day, many, many patients. But in the end, I know I don't have it, so I don't really know what's like living with it. So I tell each patient that it's about what you think is going to help you. Then we will make our decision based on that, not based on what I think.
Sure. Going back to the chats here, Frank actually asked a good question about can you have dental implants? And I will add to that, or like cochlear implants or any other implants.
So
Would
dental
that,
implants fine, but cochlear implants is not okay. The
okay,
reason why is because cochlear implants well known to move in the MRI, and if we're not careful, we can damage the implant itself. So I don't think cochlear implant is okay, but dental implants is fine. And in terms of James' question, in terms of we can still definitely do DBS after focus ultrasound, if that's your question. We can. Yeah.
I'm just curious, in terms of speech, has there been problems with speech or have you seen speech improve, particularly in essential tremor people?
The that's a great question. So
Uh,
it depends also for most patients depend on which side we're treating. Okay, for the for if you treat right side of the brain for a right-handed person, the chance your speech will get worse after procedure is very, very low. It probably will not improve that much as well. If we're treating the left side of the brain for a right-handed person, in the immediate period for the first 2 to 4 weeks, patient may feel a little bit slurred speech just from the swelling, but usually that goes away by itself over time in a month or so. That's a little bit different from the subthalamic nucleus deep brain stimulation. That does carry much more side effect in terms of speech function. And unfortunately, actually, I work on studying. I was studying this during my residency. I have a patient with DBS, and we're still really. I don't think we know for sure why exactly why stimulated subthalamic nucleus in DBS patients can change their speech. Some patients' speech get better, some get worse, but we still don't know yet. But with focused ultrasound, it's much less likely to affect your speech if you're concerned.
Oh, that's good. Lita asks, how do you decide which side of the brain to do?
That's I think what we decide together. Which hand affects you first or the most. We'll treat the opposite side of the brain. If your right hand is dominant hand, and you want that right side treated, then we'll treat the left side of the brain.
And after the procedure, particularly the first ultrasound, when patients go home the same day, are there any restrictions that people have for any period of time?
Yes, I usually tell patients if I'm driving, no driving for 2 weeks. Then otherwise, you probably will feel a little bit of brain fog for about just a little bit off for about a few days, but that usually goes away by itself in about 1 week or time. And I would just take it easy for a few weeks, just because my concern is falling because the balance from after procedure. We
Mhm.
gotta make sure you're safe, make sure someone was with you, and make sure you don't fall.
James has a great question. Why would you have DBS now that ultrasound is available?
Of course, because in the end, it's about your symptoms. If majority of symptoms is tremor, then focused ultrasound may be better. But if you're also spotted by the dyskinesia, the rigidity, the muscle tightness, the slowness of movements, those symptoms does not get better with focused ultrasound. So if you want all these motor symptoms treated, then DBS is probably a better option for you right now. Of course, there are more research what studying new targets in the brain for focused ultrasound. But for now, as I can tell you, is that if you want your rigidity, your bradykinesia, the slowness of movements get better in addition to the tremor, then DBS is better for you. Or if you feel like I need to get both sides treated at the same time, then DBS is better for you.
Any other questions from anyone? You did such a good job explaining it that no one has questions. If you have scoliosis, can I still have DBS or focus ultrasound?
I guess depends on what kind of scoliosis you have, and how bad is scoliosis. Is it like a kyphos coronal scoliosis or sagittal scoliosis? Really, I think in patient individualized. I do some spine surgery, but I'm willing to see you and kind of like help decide. Because, but of course, if you have significant kyphosis, which means your head is falling forward a lot, uh, it can be difficult to position you during procedure. I've done that successfully. It's just more tricky doing positioning, doing both either procedures, DBS or focused ultrasound. But really depends on how bad it is, the degree it is. Because every patient in the end, as we get older, we will have a little bit scoliosis. We all born develop arthritis. So depending on the degree, I will say.
And I think it's important to note that, we're specifically, when we talk about focused ultrasound, mostly talking about tremor-dominant. Like that is the most bothersome symptom that you have, right? For that's usually when we look at focused ultrasound,
That is
right?
correct. Yeah.
Okay.
Yeah, it's a tremor-dominant Parkinson's disease. Like
Mhm.
if you don't have any tremor with Parkinson's disease, you may still have the rigidity, bradykinesia, the gait problems, but focused ultrasound will not help you.
Right.
Okay?
And so focused ultrasound works on both a resting and an action tremor?
Yes.
Oh, interesting. Okay, good.
Yeah.
Elise asked, what changes or advancements do you expect to focus ultrasound?
I think the advancement these days are we're studying new targets in the brain for patients with PD. The study is not out yet. Number two is actually for brain tumor. We can stop the blood-brain barrier so that the chemotherapy can be more effective in patients with brain tumor. The third is for kind of like like epilepsy, because I also do epilepsy surgery. Sometimes they can help control the seizures for some patients. But it is a new technology, but the science is really advancing really quickly every single year. And in addition to doing the procedure, I'm also doing research on this in patients while studying our outcomes, so we can actually learn more about this. It's a process.
Mhm. It's fascinating. It's so interesting to see how far technology has come.
Yeah, I mean, I have to tell you, like 5 years ago, like I think maybe there's only about 1,000 focused ultrasound procedures a year down in the United States, maybe. Now it's over probably 8,000. There'll be 8,000 this year,
Mhm.
just because awareness of the procedure and its impact on the patient.
Will you be targeting other parts of the brain for PD with this procedure?
So for DBS, I'm doing the global pallidus internus, GPI, and STN. But for focus ultrasound, I target the ventral intermediate nuclear thalamus. There are three different targets in the brain. We target the VIM because it's relatively safer for the patients with less side effects, also control the tremor. But with DBS, you want to control the remaining symptoms of Parkinson's disease, like the rigidity and other motor symptoms, then GPI or STN is better. On the East Coast, yes, there are some centers like University of Pennsylvania. They do target globus pallidus internus with focused ultrasound. I've done that myself as well. Number one is not covered by insurance, so you do have to pay cash for this. Okay, it's not cheap, unfortunately. Number two, because of the physics of focused ultrasound, I personally think the side effects profile is pretty large for the patient. and the effectiveness, I personally I think DBS is better. That's my personal experience. If I was a patient, I would not recommend talking like lesion GPI just based on the feedback, the side effects. Because really, I tell all my patients, first thing I want to make sure is I don't want to make you worse than when you came before this
Right.
procedure, Then we'll talk about improving your symptoms.
Do you still need medication for your tremor after ultrasound?
I think depend on how much your tremor is improved. In some patients, over time, you can reduce your tremor. Absolutely. Yeah, because usually after procedure, I want you to continue taking your medication until you see your neurologist. Then if your tremor, if all you take for your medication is for your tremor, and your tremor is better, then you can talk to your neurologist about slowly reducing medications. But of course, not every patient we can do that, depending on the patient, which has a trial and error.
Yeah. So I wonder, could you explain what role your neurologist would play after focus ultrasound as opposed to like DBS where they're programming the patient
Yes,
on a regular basis?
I think I think DBS, like you tell patient, if you do DBS, actually this procedure itself is just a beginning,
Mhm.
because like it's after DBS, you need to see the neurologist every 3 months. I mean, first every month, every 3 months, 6 months to program this. And if the battery runs low, you come to me, we'll do a surgery to replace the battery. Some patient I did replace battery from 20, 30 years ago.
Mhm.
With focused ultrasound, because there's no implant, so and it's making permanent lesion, so you don't have to see the neurologist as often, which is also the benefits of the procedure, and that is why I think that's why it's we are a lot more selective with the DBS, because we only want the patient who actually we know will stay in town for a long time, for years to come. With focused ultrasound, it becomes less a concern that patients need to come back to see us like very, very frequently. Because once the tremor is gone, it should be gone.
So Phyllis said she was experiencing speech problems after her DBS in 2015. Is there any way to lessen the speech problems? Why would I be having speech problems?
I think, I mean, sorry, I don't know your case specifically, but I assume it's because of STN DBS. And I will say, the speech may get worse just with the progression of the disease itself. Okay. But sometimes the stimulation of the STN may cause speech problem as well. I will talk to a neurologist who program your DBS, and maybe they can try different contacts to help reduce the speech problems.
Mhm. I not that I want to age myself, Dr. Lee, but I am. But I know we had early on, maybe 20 years ago, when we were implanting patients with DBS, VIM,
Mhm,
or I'm sorry, STN.
mhm.
Um, we didn't have the technology that we have today for, lead localization or any of that stuff, but um I know that some people, like a young man who had DBS who was still working, who had to spend a lot of time on the phone, he was affected. His speech, his
Mhm,
motor symptoms were really well controlled with DBS, but his speech wasn't well.
mhm.
And at that time, it was before there were groups or anything like that. So again, aging myself, right? Um, he would shut his device off when he was on the phone so he could speak, and then he'd turn himself back on when he had to move. I know now with new um, programming opportunities, you can have different groups and you can switch to groups
Yes.
sometimes. But that's something that maybe you do want to talk to your neurologist about, Phyllis.
Yeah. And also, I would say, from my experience, actually, the STN was very, very popular targets for quite
Mhm.
some time. But over the past few years, actually, GPI have become more and more popular, because we realize actually if you place the GPI leads well, they can be equally effective for all your symptoms, the tremor, rigidity, bradykinesia, without the risk to your speech functions and without the risk to your cognitive functions. The, the issue is the STN is a great target, especially for tremor, but
Mhm.
we still don't really know like how we can predict how patient's tremor is going to be, how patient's speech is going to behave after the procedure.
Mhm.
See,
Mhm.
but usually when patient comes to see us for DBS, we usually have you see the speech pathologist on the same visit as well. If you already have some baseline speech problems, I personally will lean towards GPI target just because
Mhm.
there's a risk. Because we like, language is the foundation of human existence. I want to make sure you can talk.
Mhm. I know we only got a couple minutes yet, and so if anybody has any last minute questions, if not, I could keep you here all night talking to you, sadly. Do you have any idea how much this costs if insurance doesn't cover it?
If insurance does not cover this,
Probably over 100,000, I would
no,
think.
no, no, I don't think so.
No?
Maybe 20,000, 20 to $30,000.
Okay. Okay.
Yeah.
Um, all
Because
right.
it's a kind of implant, so it's a lot cheaper, I will say.
All right. And then let's see here. Speech therapy can be effective for those with speech problems after DBS. A speech pathologist familiar with DBS can work with you and your neurologist to determine how much is related to PD progression and how much it is from DBS. Absolutely true. Right
Oh, is
there.
that Leia? Well, yeah, Leia's great, by the way.
Oh,
Yeah.
well, who is Leah?
Leia, I think Leia is the speech pathologist we work with
Oh,
in program.
yay.
She's fantastic. We work on many patients together. Yeah.
Oh, wonderful.
Yeah.
Thank you for what you do, Leah. That's great. All right. If anybody's going to do any last minute questions, I'm going to share an aging story with you that I hope you find funny. When I was doing DBS, this was before they had on and off, they had devices that you could turn yourself on and off, and they gave you magnets, right? And I used to work at Henry Ford, and we were one of the first places in Michigan to do DBS many, many years ago. People would travel from all over the place to come. And I remember I would get these calls from people, maybe if they lived in the Upper Peninsula up at Sault Ste. Marie, and say, I don't know if I'm on or off. I take my magnet and I go like this all the time and I don't know. And I said, well, you're probably turning yourself off and on so much, you don't know if you're off or on. And so I would have them get an AM transistor radio and I would have them wave the magnet over their implant. And if it had a high frequency on the AM transistor radio, we knew they were on. That's some Fred Flintstone stuff, isn't it?
Yeah. I saw some patient with really the oldest DBS system. It's really different. The leads look so different, like
Oh, very.
20, 30 years ago compared to now. Even
Yeah,
DBS itself, the technology advanced so much.
it's
Like I
crazy.
recently implanted the first new Boston system in the
Uh-huh.
state with like the 32 contacts. Now they have directional leads in 5 different levels. It's crazy what technology is going. So
Yeah,
yeah, I think both DBS and the focus ultrasound are all getting better,
yeah.
and we'll have new and more better therapy for our patients in the near future too.
Yes. Does AI have any role in functional neurosurgery?
Yeah, actually, I think AI has a role in everything. What AI has, I think AI probably replace my job in 10 years. That's my prediction. But yeah, for functional procedure, it's a lot of technology. And I use pretty much in every software and hardware, like all the robots we use, pretty much there's AI built in almost every single program now. The Focus Ultrasound program has AI to help me find the targets in the brain. The robots we use have ability to merge images. We use AI to merge images. The the DBS program itself, Medtronic and Boston, they have AI involved to help programming. So
Mhm.
with development AI over the last few years, I think everything's only getting better. You know,
I
I
agree.
think with the newest Boston program, the idea is that they can based on the lead location, they can program itself, give it a setting, and then your neurologist will find like adjust it based on their initial programming by the AI, and
Yeah.
that being shown to make it much easier for the patient and the neurologist and save time.
Oh,
That's
for
all.
sure. I mean, when people would come in for programming, they were in our office for like 6 hours and
Yeah, not anymore. Yeah.
no, not anymore. No, I think it's wonderful. Well, I don't see any more questions unless anyone wants to come off of mute. So if anybody does have any questions, you can always reach out to me. I'm sure I could reach out to Dr. Lee and ask him any questions as well. I want to thank you very much for doing this program. If anybody wants to look at this information again, it will be up on our YouTube channel within a couple of days. And thank you very much, Dr. Lee, for all your dedication towards the Parkinson's community. We need it.
For sure, I can't really imagine what's like living with it. I do what I can to help patients. That's what drive me to work every day. See patients, like today, see patient tremor gets better. That's what drive me to work. If you want to see us, see our team, I said we do it with a integrated team-based approach here. Just give us a call or email us. We're always here. And I hope, you're like we can improve the technology, and we hope we can really find a cure for Parkinson's disease in the near future.
Oh, yes,
Yeah.
that's our hope. Well, hopefully you'll join us back for another program too, as well.
Okay, for sure. Yeah, thank you for everyone for your time.
Well, thank you, Dr. Lee. Thanks, everybody. Just a reminder again, we will not have a VES next month. It will be in August. All right. Thank you.
Thank you.
Good night.